And here we see some of these software that is used for evaluating thoracic and abdominal aortic aneurysms. This is 3D CAT scan reconstruction, patient with skin on, with skin off. And in this case, the patient has an abdominal aortic aneurysm that we can see here at the mid-lower abdomen. We can see most people want to know where their abdominal aortic aneurysm occurs. And in this case, here's the belly button. And with the skin off, one can see the abdominal aortic aneurysm in its, in its most common location below the renal arteries. And here's one of the very important features that we are evaluating for a patient with an abdominal aortic aneurysm. We want to see where what is called the aortic neck, how long that is. And that's what distinguishes a patient that's a candidate for conventional endovascular aortic aneurysm repair with a stent graft device when this area below the renal arteries is sufficient in both length and diameter. This particular patient that I'm showing you here is what's called a pararenal abdominal aortic aneurysm. Has no distance between the right renal artery, the left renal artery, and the aneurysm encroaches upon both of these arteries, making this patient not a good candidate for standard endovascular aortic aneurysm repair, perhaps some investigational or other devices, but not standard endovascular aneurysm repair. Using this same technology, we can look at the blood vessel in a cross-sectional view. Imagine if a patient is lying here on the examination table, and right now we're looking up through the patient. So imagine the feet are at the bottom of the screen. My cursor is pointing towards the pelvis. Here's the abdominal aortic aneurysm, which is a tube. The aorta is a tube which runs from the chest, from the heart through the chest into the abdomen. Excuse me. And in this instance, I'm showing you a different view where we have literally looked at the patient through very thin slices. This is in the chest or thoracic cavity. Here's the heart, the left atrium, the left ventricle, the aorta, the blood vessels that originate from the aorta, the innominate, left carotid, left subclavian artery. And then we can see as one makes our way through the chest, the right thoracic, the left lung, and then we enter the abdomen with important blood vessels that originate from the anterior aspect of the abdomen, the celiac trunk, the superior mesenteric artery, and here are these arteries, to the kidneys, the right renal artery, the left renal artery, and in this case, the patient has this aortic aneurysm, which begins at essentially the level of the renal vessels. And so this is the cross-sectional imaging that's very important and valuable in the evaluation of a patient with abdominal aortic aneurysm or thoracic aortic aneurysm dissection pathology. We use this same software technology to evaluate patients with occlusive disease of the lower extremities. It's invaluable in preoperative planning for these patients in terms of strategies which might involve open surgery, endovascular surgery, or some type of hybrid approach, employing both minimally invasive as well as surgical incisional approaches to a disease. And so I think this is a very, very important for patients to understand that these are the considerations, and this is the detailed imaging necessary to arrive at a sound strategic approach to each disease process. And this is why I tell patients that the strategies to managing pathology are based upon their individual tailored anatomic pattern, their presentation, as well as their comorbidities, their medical comorbidities. Many times patients ask, and they come to the office with this expectation that perhaps they've read or heard about some technology. Maybe they've heard through a friend, maybe they've read about it, maybe they've even heard through one of their primary care physicians that refers them, and not necessarily understanding that whatever approach, surgical or minimally invasive technology that they heard about may not be appropriate or applicable to their anatomic disease pattern. That is either their anatomy in isolation or their anatomy in combination with their age in life, their life expectancy, or their medical comorbidities. And I'll give you the best example of this is that for patients that present with an abdominal aortic aneurysm that is of appropriate size and warrants treatment, there are two polar opposite age categories and comorbidities profiles that I can describe to you that will give you an example of what I mean. And so let's say perhaps a patient that's 55 years of age has an abdominal or thoracic aneurysm. They are young, they are very healthy, they are active. Their life expectancy, if one looks at an actuarial insurance table for a male, they'll live to the age of 78, a female to the age of 81 or 82, depending upon what demographic profile they have, compared to a same patient, same anatomy that presents at the age of 78. They've been in the hospital multiple times for cardiac and heart attack or stroke, or just basic frailty issues that occur at the end of life. There's a fundamentally different approach, even though they have the same anatomic disease pattern to management of these patients. More inclined for an open surgery in the patient that's younger of age, same anatomy, because that patient will undergo surgery in good hands with a good team. They will have an outstanding outcome, a good technical outcome. They will not require some of the radiographic continuing surveillance, X-rays in the form of CAT scans that are requisite for surveillance of patients undergoing endovascular repair. For a 55-year-old person, that might be a CAT scan, ultrasound or CAT scan every 12 months or so for the rest of their life. Sometimes we can mitigate the use of CAT scans, but there'll be some form of radiation exposure for the rest of their life in surveillance, and there is a failure mode of all endovascular devices versus a patient with open surgery, undergo surgery, get a good outcome, and still require some type of surveillance, but not necessarily the same frequency and the same magnitude of a patient undergoing an endovascular aneurysm repair. On the other hand, the 80-year-old patient with a lower, shorter life expectancy, a higher comorbidity profile, unable to perhaps undergo open surgery, might be more suitable for an endovascular repair. So I hope this helps in explaining to everyone how we use these various radiographic, angiographic modalities to arrive at a decisional process regarding the therapeutic options for thoracic or abdominal aortic pathology.